My name is Stefan AGEWALL. I'm a professor of cardiology at Oslo University in Norway. I'm also the editor-in-chief of the European Heart Journal Cardiovascular Pharmacotherapy and the past chairman of a working group of cardiovascular pharmacotherapy in ESC. During this congress I'm going to discuss MINOCA, that's myocardial infarction with non-obstructive coronary arteries. And recent studies and meta-analysis has shown that this is quite prevalent, with the prevalence figures around 6 to 7%, and we are actually not knowing how to handle it. Previous studies has shown that the prognosis is better compared to those with standard coronary artery disease with obstructive coronary arteries, and the mortality after 1 year is about 4.5% compared to 6 to 7% in those with a coronary artery disease. So how could we identify these patients, and how should we handle these patients? Well, after doing an angiogram we have to think again. These are a working diagnosis, MINOCA, and we have to think what's the background, pathophysiological background to this condition. And then we have to look at the angiogram again and maybe do some extra examinations to look for dissections and spasm and things like that. And if we can identify the pathophysiological background, that is fine, but in many cases we cannot. And our working group has recently published a position paper, and in these patients where we don't have an obvious background for the MINOCA, we suggest that MRI is the examination of a doctor to choose. And by doing that, we have shown, and others have shown as well, that we can identify the diagnosis in 70% of the cases. So this topic has got an increasing interest, and apart from the position paper from our ESC working group, the new ESC STEMI guidelines will have a section about MINOCA, and also the American Heart Association will publish a position paper of the definition of this condition and how to proceed.